So, Eric, you're an economic historian currently working at the University of Sussex in Brighton, and I think you're moving to the London School of Economics very soon. We first met and started to collaborate because we were co-organising a conference which I think we called Beyond Birth Weight. From your perspective, what was the reason for focusing on birth weight, human birth weight, as something which was worthy of an interdisciplinary conference?
Yeah, I mean, so I had been doing some historical work on kind of how health had changed over the last 200 years and how that might affect kind of growth, postnatal growth and other things, life expectancy, things like that. And one of the things that really struck me when I looked at some of the evidence is that birth weights and birth weight distributions seem to be very, very similar in the 19th century and today. And even looking at the US vital statistics, which provide really kind of distributions of birth weights for a very large population, there's been very little change in these distributions between 1950 and the present. Maybe a slight increase up to about 1980 and then a decrease again back to the 1950 levels. And so I found this very striking, and especially given all the other changes in medical technology and in kind of other social factors like smoking prevalence that would have affected birth weights. And so I figured out that I didn't know enough about this, and I probably needed to talk to some experts to find out what this meant and how I could contextualize that. So I think that was my starting point.
So I think one of the things that I was bringing to the meeting as a physiologist, in conjunction with clinical colleagues in obstetrics and gynecology, was again a focus on birth weight, but now looking back into fetal life and thinking about how the dialogue, if you like, the conversation between the mother and her fetus during development affects not only birth weight but the trajectory of fetal growth. And it became very apparent from some of the data that Professor Visser from the Netherlands showed, I remember, which was a study of 1.1 million normal healthy births in the Netherlands, where they showed that the risk of death in the antepartum, intrapartum and neonatal period was actually shifted to the right. In other words, to slightly bigger babies in terms of birth weight than the median, the average distribution for the whole population, suggesting that what was good for the mum in terms of growing a baby so that it could be safely delivered was rather different from what was good for the baby in terms of its survival later. So I think that at the meeting made us begin to think, well, what's going on in fetal life here? How is this discussion playing out and what's involved in it?
Yeah, and I mean that fit really well with some more recent findings. Looking at fetal growth in the first trimester and linking that to cardiovascular outcomes, or looking at kind of fingerprints which are formed in the first trimester and linking those to kind of risk of diabetes and things like that. And so that there are other processes in development that are affecting kind of long-run health outcomes that we just completely miss when we focus solely on birth weight.
So that was the Generation R study, wasn't it, where they were looking at fetal growth in the first trimester and how it might relate to cardiovascular risk in school children. And I suppose that really led us to consider the paper that had literally been just published in The Lancet from the Intergrowth 21st study, which had taken a selection of women from several countries around the world, looked at the trajectories of fetal growth. And these women and their families were well-nourished, high socioeconomic status with normal obstetric outcomes. And so the conclusion from that was that if you put all these together, you could come up with what the authors, I think, call an optimum trajectory for fetal growth, which might be a sort of a universal standard across the whole globe for fetal growth. And I remember that really caused some quite heated discussion at the workshop, didn't it?
Yeah, I mean, it's very puzzling in some ways as well, because although the Intergrowth study had tried very hard to select kind of high socioeconomic status women who were healthy there were still some kind of population differences based on kind of the geographic sociocultural context. So, for instance, women in India and Oman, which were two of the countries that they studied, were substantially shorter than women in kind of the other countries that they looked at. And those two countries also had lower birth weights. And so this raised some real questions about, the kind of interaction between, again, the mother and the fetus, and how maternal constraint may be kind of, shifting what might be, an optimal level of fetal growth based on the population in a way that maybe the intergrowth study wasn't accounting for.
And it's certainly very difficult when you begin to apply that data to a particular population. I remember Professor Kiserud from Norway telling us about the data in Norway that would suggest that if you applied the intergrowth 21st optimal standard to Norwegian babies at 32 weeks gestation, and then look at the 10th centile of growth, you'd find actually that a high proportion of Norwegian babies are too big. They're falling outside that. And so that would make you think, well, are these babies perhaps being overnourished? Is there a much higher incidence of gestational diabetes, for example, in Norway than one might think elsewhere? And I think Professor Kiserud and colleagues were worried that applying this might then lead to an increase in the rates of caesarean section, not just in Norway, but in other parts of the world where we're already worried that they're too high. So the application is really quite difficult, isn't it?
Yeah, it is. And it's difficult to know what interventions would be effective and which ones would actually do more harm than good. And it's also, I think, difficult to understand exactly what we would gain from comparing all children against this one standard versus comparing children against a reference that was created from their own population. And that might be actually more useful than trying to create some kind of international standard. And I mean, another thing that we began to talk a bit more about was basically how, fetal growth, and especially birth weight, is a process rather than an outcome, right? And it reflects developmental adaptations to the environment. So do you want to add a bit more about that?
I think that's a good way of putting it. And of course, what we're learning really from these studies of cohorts around the world is that this interaction between the mother and the fetus is occurring across the normal range. This is normal human biology. And so the worry that if we try to standardize it and say, well, only this particular trajectory of growth is optimal, then what are we saying about these pregnancies and those families that are having otherwise healthy babies that are growing outside that optimal range?
Yeah.
And I suppose, in a way, Eric, there are much wider concerns as well. I mean, who's actually going to decide what is optimal? Is it the scientist? Is it the doctor? Should it be the family? Should it be society at large? These are really big questions.
Yeah.
I think as we're talking here, it makes me realise we've only perhaps just begun to scratch the surface of this area that clearly needs more interdisciplinary research.
No, I think that's definitely right. And I mean, one of the real tricks that I think we've kind of been talking around a little bit is that it's very difficult to take a population reference and apply it to individuals, because so much of kind of fetal growth and growth potential is inherited either epigenetically or genetically. And so it becomes very difficult to distinguish between a child with a high growth potential, a high inherited growth potential, who experiences intrauterine growth restriction, and a child who's kind of in the middle of the range and kind of experiences, middle conditions and ends up with the same birth weight. Those two children might look very similar, but they have a completely different physiological process that's taken them to that given birth weight. So I think through interdisciplinary kind of collaborations, we can begin to move and join the kind of population side and the kind of scientific development side, and maybe come out with some new insights on this.